Okay, it's 12:30, so let's begin. My name is Anthony Bogues. I'm a professor here at Brown and the director of the Ruth J. Simmons Center for the Study of Slavery and Justice. One of the ways in which this center operates, let me just wait till folks come in and find seats. One of the ways in which the center operates is that at the academic level is that we divide the work we do into what we call research clusters. We have a research cluster on human trafficking, led by Eleanor Shee, who is a member of the Faculty of American Studies. We have another research cluster on race, slavery, and the making of the modern world, led by myself and in collaboration with a scholar from University of Amsterdam. And we all have another research cluster called on race and race, medicine, and social justice, co-led by Dr. Braun and Dr. Wilson. And I would say to you, as the director of the center, that this particular research cluster has been one of our most active and most interesting. When we first talked about it, that many people thought, why are you thinking about race and medicine? Well, medicine's a neutral business, so why you want to think about that discussion of race? But we have found that under the leadership of these two academics and one medical doctor, that this has been not just robust, but really trying to work with medical people and thinking through two things. One, health disparities that are based on race, which are just, which everybody knows. COVID has shown us that. But also, very importantly, thinking about medical knowledge itself. What it is that goes into a young doctor making a diagnostic of somebody. What kind of things does he or she bring? What frame does he or she have as he or she is making that diagnosis? And so it is really with great pleasure that when we were asked what forum we wanted to do this year for commencement, we actually had no problem in saying, let's do the race and medicine research cluster. So I want to thank both Dr. Wilson and Dr. Braun for leading over the last 2 years this particular research cluster, and to say just how grateful we are for the work that they have done. We will have 4 speakers, as you can see on the platform. They tell me they'll try and speak for about 7 minutes each, so that's about 28, 30 minutes. Give them a few more minutes, it might make about 35 minutes or so. We have an hour because we have to get out of the room because the forums are back to back. But we want to leave a little time for Q&A so that you can all ask whatever questions. So to make it easy, rather than me getting up 4 times to introduce people, I'm just going to introduce all of the panelists, and they will speak in the order that I have introduced them. Professor Lundy Braun is a CSSJ faculty fellow and co-chair of the Race, Medicine, and Social Justice Research cluster. She was a Royce Family Professor in Teaching Excellence, and she's a Professor of Africana Studies and Medical Science. And I would say to you, in my earlier years when I was Chair of Africana Studies, that she was really a very important figure in that department while I was Chair, trying to bridge the business of medicine and Africana Studies. She's, of course, as I said, a Professor of Africana Studies, Pathology, and Laboratory Medicine in the Alpert Medical School of Brown, and is a member of the Science Technology Society. To me, one of the most important things about her is her award-winning book, Breathing Race into the Machine, the surprising career of the spectrometer from plantation to genetics. And whenever I have a particular question to ask her about questions of medicine and science, she's actually my go-to person. The other speaker is Dr. Taneisha Wilson, who is a CSSJ faculty fellow, and she's a co-chair with Lundy of the Race, Medicine, Social Justice Research Cluster. She's an assistant professor of emergency medicine. She's an attending physician, and she's at Brown Emergency Medicine, and she's director of equity initiatives in the Brown Emergency Medicine. She's an accomplished assistant professor of emergency medicine at the Alpert Medical School with a really strong track record of research and clinical experience. She has had numerous awards for her work in anti-racist and medicine. And I think very importantly for African Americans, her work includes working with patients with sickle cell disease and their providers to develop and implement strategies to improve patient care. Dr. Wilson is committed as promoting physician wellness and workforce diversity. And I hope that she continues at the center. She knows why I'm saying that. Our third speaker is Dr. Dannie Ritchie, who is an adjunct assistant professor of Africana Studies and a clinical assistant professor of family medicine, a member of race medicine and the social justice research cluster. She has a master's, she's an MD and an MPH from the University of Chicago, completed her residency in family medicine, and works a lot at the community level to try and shift policy perspectives. She is, I think, as an academic, her appointment has allowed her to teach Brown undergraduates intersections of race, class, and gender, and on policy and reproduction of health disparities and inequality. I think what she will be proud of, because I know she talks about it a lot, is that in 2011 she established a community health innovation of Rhode Island, an organization that acts on the determinants of health disparities and inequality. So she's not just an academic or a doctor, she's very much involved in trying to think through questions of community and wellness and health disparities. And the final speaker is Mr. Eric Jones, who's a PhD candidate in Africana Studies and a member of Race, Medicine, and Social Justice Research Cluster. He is, I would say proudly, a former student of mine. He took a class with me in Africana Studies. His PhD research is trying to think about the United States Steel, Clarendon, and Coke Works, and how this particular plant impacts public health in surrounding communities across several generations following the Clean Air Act of 1970. He is, in my view, a very talented and gifted Africana Studies student, and one expects a great deal from him. So those are your speakers, and I will start with Lundy, and they will just go around without my introduction. Once again, welcome to this particular forum.
Thank you.
I think you might approach the speakers, please.
So thank you very, very much, Tony, for that kind introduction to the panelists. And thank you all for being here. I have some laryngitis. I'm not contagious, but it's just going to be a little annoying, I think, but I apologize. The overarching goal of our research cluster has been, over about 7 years now, really twofold, and we've maintained this thread throughout, to interrogate first the various dimensions about race, how race and the how is important, how race and racism work in contemporary medicine and science and public health. With a focus, as Professor Boakes just said, on knowledge-making practices. And then secondly, what we have fostered is collaborative research and action. And we've done this in a variety of ways. One is in the House, participating in the House Ways and Means Committee on the use and misuse of race. There was a space for both theorists and activists to merge our interest in this collaborative research cluster over the years. I'll just tell you a little bit about the specific questions we asked, because the nature of the workshop flowed from the questions. We asked when, how, why, and if race should be used in medicine. When, how, why, and if. And this question was woven throughout our work. And then an important theme throughout our work was, what is the history of the use of race and racism in medicine, and how does this history shape contemporary practice? So how does the history that is being uncovered by many scholars and activists, how is this history shaping the practice now? I mean, what I've always used is Michel Rolfe-Trouillot's famed notion of how does the past live in the present. And I think that is what we have done over all these years. Science, medicine, and public health have been and continue to be central sites for the naturalization of racial difference. And by that I mean they have been central sites where racial difference is rooted in our DNA. That notion has contributed to the idea that racial groups are genetically defined. This is a problematic notion, as I'm sure many of you know, and it's a notion that's deeply intertwined with colonialism, slavery, and their ongoing legacies. So teasing apart the ongoing legacies has been an important aspect of our work. As many of you know, this history has been strongly contested at different historical moments. Medical students have been especially important in the last maybe decade in asking questions about why are they hearing from their professors about race as a genetic entity. As many of you do know, this history of racialization, though, is often invisible. And the invisibility of everyday science, everyday racism has been largely ignored until very recently. This set the stage for the reinvigoration of ideas of innate difference under the guise of health disparities. So many are starting to look at how have we framed health disparities that has led to these problematic notions. We are thus witnessing a revitalization of the idea of racist biology, most recently framed as racist genetic ancestry. The Simmons Center, previously known as the Center for the Study for Slavery and Justice, when we first launched the research cluster in 2014, this research cluster began with a keynote talk by Professor Dorothy Roberts from the University of Pennsylvania, who had published an outstanding book that everybody should try to read as much as they can. Every single chapter in this book is a jewel, and I've read it numerous times. I teach it in almost every course I teach. It's entitled Fatal Invention: How Science, Politics, and Big Business Recreate Race in the 21st Century. In 2016, she published an impressive article, a short article, entitled Taking Race Out of Human Genetics. And with that, she laid the gauntlet down. Taking race out of human genetics is still being investigated, and there's many symposiums about it, but her talk with an interdisciplinary group of scholars, historian, evolutionary biologist, and Professor Roberts is a legal scholar, has informed the work of the cluster, even long after she gave a keynote talk. So I'll just let you know a little bit before I turn it over to my panelists what this cluster looks like concretely. So the cluster is comprised of an interdisciplinary group of faculty and students from the campus and from the medical school. So this is pretty unusual that you have scholars working together from these two very, very different spheres. And we discuss issues that have been circulating around race and genetics. We met 3 times a semester with one invited speaker. We explored current scientific papers that continue, unfortunately, to come out. And some of the topics were racial classification, racial essentialism, algorithms, race-based algorithms that you might have read about in the press, algorithms such as those for kidney function, for pulmonary function, for let's see, VBAC, vaginal birth after cesarean section. We have looked at papers on the history of race in medicine, including mental health, tuberculosis, a very deeply racialized notion that is coming into vogue called metabolic syndrome. It's such an incredibly problematic notion, but the racism slipped into it. And Professor Tony Hatch from Wesleyan wrote a book on metabolic syndrome. We looked at racism in public health in Cuba and how the structures of racism are built into housing, one of the most important dimensions of societal dimensions of poor health. That if we don't do something about housing, we can achieve actually very little. We took a global perspective throughout. I don't want to go over. We took a global perspective throughout, and many of us focused on what was invisible. I had the good fortune to participate in many seminars and with activists in South Africa, particularly asbestos activists, that informed my thinking in the US and informed my thinking in the research cluster. I'll just conclude by saying that the use of race in genetics research remains a contentious issue. It was a very contentious issue when we began. It remains a contentious issue in the biomedical sciences. How can this be in the year 2023? I get asked this almost every talk. Why does racism persist in medicine? And that's, of course, a question. Why does it persist in society? There was an NIH, National Institute of Health mandate in 1993 to remove or to include women and minorities, is how they framed it, in all health research. But what happened was just documentation and no real interrogation of why. So I don't want to take up any more of our time, but I do want to just end with saying that what do we need to end racism in medicine? Well, first of all, we have to see it. We have to recognize that it's there and not deny that it's there. And that's actually pretty difficult. And as I'm sure many of you who are nodding know well. So how and why does racism become such a pillar of medicine? And what are the processes? So I think we really need to focus much more on the processes by which it permeated medicine to its core. And can we just tweak it away? Can we just remove one little racist dimension of an algorithm and have racism disappear from that particular field? My colleagues here will continue and tell you about their work inspired by the cluster.
Thank you.
Thank you, Dr. Wilson.
I am hard-pressed to follow that introduction of our work, so I am Taneisha Wilson. As an emergency physician, I want to start out by presenting you with a case, one of my very first cases as a resident. So I did residency here, I did fellowship here, I stayed on here as faculty. I've been here for about 10 years now. And one of the first patients I treated as a first year in one of our smaller community hospitals was a young man suffering from asthma. He was having an asthma attack. He was obviously deeply melanated, right? He had obvious, recent ancestral roots on the continent of all of our origins. His asthma was not just a result of the degree of his melanin content in itself. As we know, our skin color does not really define what is inside of us. Race, again, is just colloquially skin deep. But we know that his presentation with this severe asthma attack was rooted in the narrative of our socioeconomic disparities and structural racism. So JB, we'll call him JB, could trace his roots as far back as Georgia. I mentioned that one of his parents could trace their roots to 1799 in the hills of Georgia. And one of his parents actually recently immigrated to the United States to Rhode Island in 1899. And he identified as both a Black and a Cape Verdean American. And though his family had been in the US for hundreds of years, right? And you could clearly tell that he did not always have access to consistent health care. And why was that? This person is as American as any of us could get. His family, for the most part, had always lived in very similar neighborhoods, industrialized neighborhoods surrounding bus lines, airlines, train stations. And in fact, he lived right in one of our industrial neighborhoods now in the middle of Providence. So not only could JR really describe the biases that impacted his own treatment, his encounters with the health system itself was really mired in bias. There was a time he described coming into the ED, into the emergency department. I use the term emergency department, not emergency room, because now we're huge, not just a little room in the basement of hospitals like we used to be. He described one moment he came into the ED really gasping for air, and it was told to stop being dramatic. He had to come to the ED because he had ran out of script for his inhaler. And he ran out of the script for his inhaler because his PCP would not fill, the primary care physician wouldn't fill the script because he'd missed 4 appointments for checkups with his PCP. And so they did it, they prescribed it without the appointments twice. But the third time, the PCP was like, no, I have to see you. I don't know how sick you are. I have to see you. But JB was like, I can't make it to the appointment because I am a general manager at one of our local grocery stores, grocery chains, and all my pay time off is helping my sister take care of our mother who's suffering from dementia. And my PTO, I feel guilty using it for myself. And I can't take any more time off because we need the money, because we can't afford to put our mom in a nursing facility because we don't have the resources to do so. And so my sister, I support all of us. So JB's supporting everyone in his home. And so couldn't take time off. And he ended up in the emergency department gasping for air because he did not have a refill of his albuterol inhaler. And he needed this albuterol inhaler because his environment, right, where he went home to sleep at night was triggering an asthma attack. So all this, right, as an emergency physician, I'm getting within 5 to 10 minutes of an ED visit. Granted, my visit with JB lasted more than 5 minutes, but seeing 40 patients in an hour, and I think if there are a lot of physicians in the room, most of us both in hospital-based medicine and the clinical, actually the clinics, so the outpatient setting, are under this pressure to see all our patients so quickly. And so some of us don't quite understand the context. And I know if his primary care physician understood JB's context and the fact that really he couldn't make it to those appointments, perhaps a telehealth or a phone visit would be beneficial to JB just because she couldn't get that. And not because I'm sure she didn't want to, but because we're so pressed for time. And at the end of the day, you know, after you've seen 40 patients in about 8 hours, you know, there's charting and follow-ups and all the things that you have to do. And while I don't do outpatient medicine, I can only imagine what my colleagues in the outpatient setting experience, right? So almost every person who comes in front of us in our acute care setting has a story like this. Melanated, unmelanated, almost all of them from lack of access. But unfortunately, it's the folks with the most melanin content that seem to bear the brunt of these stories. And over the past several years, our cluster has worked really to unravel and address these intertwined narratives of race, racism, and at the end of this, knowledge production, right? So we have focused on this interdisciplinary approach. We've talked to folks from various fields to try to illuminate why this is so pervasive to us. And as an ED doc and a member of our cluster, I do have really that frontline perspective on how our socioeconomic disparities can impact the health outcomes for all of our patients. And, you know, I feel like our work here we have tried to scrutinize how these disparities continue to function and work. And we've had the privilege of learning from scholars who really trace that linear impact of historical moments like chattel slavery, right? The failures of Reconstruction, the Jim Crow era, and thinking about JB redlining and how it impacts our present healthcare landscape, right? But I feel like, you know, we've explored other controversial topics as well, you know, things like physician labor unions, delving into how physicians have tried to organize themselves, especially now resident physicians in New York, to address not only those working conditions, trying to take care of people, you know, with 5 minutes at a time to make a connection with the human. It feels overwhelming. And at the end of the day, this impacts our patient outcomes. So while our cluster's journey had, you know, led us to, you know, many really different topics about race, genetics, and even some of our cluster members have some trouble, I think Lundy and the team would agree, understanding how race and genetics and our healthcare outcomes are not as linearly integrated or intertwined as we have been taught as physicians, med students, and residents. So obviously our mission, you know, remains to really promote the understanding of the pervasive effects of racism on health and on knowledge production. And we work to challenge ourselves, you know, as we move forward in an effort really to foster these dialogues, because if you are someone in this room who believes that the melanin content of my skin really impacts how my kidneys function, then this talk might not reach you in any way. Because we all have the 2 kidneys, the 1 heart, 2 lungs, the brain. Epigenetic factors do matter, you know, where we live, our lived environment impacts those things. But at the end of the day, if we were all born in the same utopia, right, in the same green space, access to the same healthcare, access to the same schooling and knowledge, perhaps some of us, you know, we're not gonna all be judges and doctors, and some of us might not even aspire to be that, but what we do know is that we're made the same. It's things in our environment that impacts our outcomes. And if you don't really believe that, I'm not sure our talk today will convince you of that, but those are the facts. And our cluster really tries to work on understanding as both, you know, as public health advocates, epidemiologists, and physicians, how we can recenter the narrative in order to really impact outcomes for our patients, whether that be with policies, you know, speaking to our senators, or just on a day-to-day basis with that patient in front of us. And so that's kind of what the cluster has meant for me, and I'll pass it on to Dr. Ritchie. Thank you all.
Thank you for that. There's so many places I could go with it, but first I'd just like to say that I identify myself as a scholar activist, and I'm very involved with understanding how policy shapes where we live, learn, work, and play, and always about how we need to address those things to change the conditions in which we live in. I'm a social medicine physician, which means that I went to an allopathic residency that was very specific about understanding social conditions and how they impact your health. Social medicine was coined by Virchow, and Virchow was considered the father of cell biology. What's interesting about Virchow is that we have to learn about him in medical school because of all of his contributions to the defining of certain illnesses and diagnostic processes. But we don't hear about his activism. Virchow said, medicine is a social science, and politics is nothing but medicine on a grand scale. And that's how I live and learn and work and continue to understand and how we change those impacts. One of the things that my 15 minutes of fame has to do with really is looking at how the US government used priority areas to place physicians, because I was a National Health Service Corps scholar, and that's how my medical school got paid for. And I wasn't allowed as a family physician to stay where I was raised in New York and where I practiced in the South Bronx. And I ended up choosing Indian Health Service. But part of that process is that I actually questioned what were the processes, how they were making these determinations. And at that time, there was an article that came out that showed how African American men in Harlem died at a younger age than those in Bangladesh. So it's using the research and to actually interrogate what the policies were that structured how it was okay to send me away from my home. But what happened was, one of the things that I ended up with the Tohono O'odham and the Pima, which is, most people know about the high rates of diabetes among Native Americans. And there's the still incessant idea that it's called the thrifty gene, that somehow, because through the genes, Native Americans are more predisposed to being able to get diabetes. And I even coming out of residency, kind of thought that sounded logical. But as I was there, I learned that in World War II, in the 40s, when they needed bodies, right, for the war, and they went to Native American reservations, people were starving and dying of tuberculosis, and they couldn't find people strong enough. So they started giving commodities, stripped them of their diets, well, which was already being stripped, right? And within 20 years, you started seeing the onset of diabetes. And then this continual research and pouring into research to try to decipher that gene, right? In the 1980s, our policies started to make public schools have to have vending machines to support themselves. And it was filled with Pepsi and Coke. Within 20 years, we started seeing a process of diabetes amongst children, right? And then it was like, oh, it's the diet. Oh, sorry, I'm sorry, I get a little bit too with that, but. So, I work to expose these things. I work to try to make sure that we're not constantly talking about our genes. Because what it is it's a dominant cultural narrative, right? It's a dominant cultural narrative of predetermination, of biological determinism. And it's just wrong, right? So we're, in the cluster, we're talking about these things. We're talking about the language and the epistemology and how it's framed and how it's developed, so that we can tease it out and we can start to direct the conversation differently in the medical school and in our communities. So I come here, I'm actually 20 years getting my MPH here at Brown. And I started the Community Health Innovations of Rhode Island almost 10 years ago, actually became an official nonprofit. But we're looking at how do we get the community involved in this conversation? How do we shift power, right? And how do we start to understand those social determinants of health, where we live, learn, work, and play, and how, again, that they are determined by the policies? Providence is a tale of two cities. We're here on the east side. One of the things that I teach is about housing. What were the policies? We talk about redlining, right? What created these two cities? Well, let's look at urban renewal. That was just 50 years ago, right? Where the largest Black population, which was on the east side, was being systematically removed from the east side. And then we have the highways built. And it separates the east side from the rest of Providence. And those highways, right, and the industrial factories are on the west side of the highway. And so then you see the asthma, right? This isn't something that's genetic. It's about how we structured our communities, and that is the racialized structuring. That's what we're talking about when we talk about structural racism. And how does the state, the federal, the state, and the local governments collude to create these conditions? It's not about personal animus. That plays into it. But there's an active part in policymakers in determining the places that we live in. So I look at issues around housing. I teach about that. The students learn about how their space and their position at Brown actually has impacted the conditions and where people live. We talk about food. We have a garden just a mile away. The place that I'm talking about, if people don't know, Lippitt Hill and Mount Hope is just a mile north of the campus. And that's where the population was moved from. So looking at that violence, it's the violence, right, of the removal. And it's the violence of structuring the conversation around somehow it's genetically determined. And that's what we work at. And so my work here in the cluster has been to be with others that we can help talk together about these issues and be able to learn, think about how to teach it. And one of the things that I developed in the cluster was to say that we are not born with it, we are born into it. We see the impacts of the health of the conditions that act on our biology, but it's not something that comes naturally because of our biology. And then if we can understand that, we can start to think about how do we change that. And I'm done. Okay, so thank you.
Thank you so much for that insightful piece of work in the community. I think it's what's really incredible. And now our final speaker is Eric Jones, who's flown in from Washington, D.C. to be with us today. Eric.
Thank you, Dr. Braun, Dr. Wilson, Dr. Ritchie, for your insightful comments. I think in my prepared statement, what I have to say is going to essentially echo what was already discussed. But before I get into my main points of my prepared statement, I want to share that my introduction to the race, medicine, and social justice research cluster predates my time as a PhD student at Brown University. In fact, it started when I was applying to PhD programs several years ago. While preparing for my interview with Brown's Africana Studies Department, I drafted a Word document with 3 sections that each posed a question. Number 1, why do you want a PhD? Number 2, why are you interested in this program? And number 3, who are you interested in working with and why? In the first section, I noted my personal experiences that ultimately shaped my research interest in racial health disparities. I emphasized the need for scholarship that goes beyond the proverbial ivory tower and engages the public. I wrote that I believe one of the pathways towards racial equality and equity is the eradication of health disparities, because I sensed health disparities are an offshoot of social, political, and economic factors that are generally deprioritized, and that was echoed in the previous statements. In the second section, I detailed how the PhD program would expand my perspective on health inequality. I discussed potential interlocutors in other departments, such as the School of Public Health, that could aid my research. In addition, I highlighted the Africana Studies Department's relationship with the Center for the Study of Slavery and Justice and its research clusters, specifically race, medicine, and social justice, ironically enough. And in the third section, I listed Dr. Lundy Braun and explained why I believe her research interests would enhance my intellectual development. And side note, I'm not trying to gain brownie Dr. Braun, I'm just stating my truth. But I share this anecdote because my research is a professional and personal venture. Also, the opportunity to share my perspective as a graduate student on this research cluster is a watershed moment for me. So I'm going to highlight 3 points as it pertains to the research cluster's work and its impact on me as a graduate student. A, it has exposed me to insightful scholars that have broadened my scope of health inequality. B, it has helped me understand the significance of knowledge production. And C, it has served as an incubator for understanding the perspectives of medical doctors and students. The Research Cluster's lecture series has enabled me to consider health inequality from numerous vantage points, whether that is looking at the connection between religion and biomedicine, the ongoing implications of Ebola in Sierra Leone, the racialization of opioids, the issues with tracing genetic ancestry, the idea of the transatlantic slave trade and colonialism ushering the rise of epidemiology, among other topics. These lectures have demonstrated the complexity of race, health, and social justice, not only domestically, but globally. Moreover, these lectures prove that science doesn't necessarily operate within a vacuum. Rather, it operates within a social order, necessitating the need for interdisciplinary scholarship. So for instance, during Black History Month in 2020, the School of Public Health hosted a live webcast of Taneisha Brown's keynote at the University of North Carolina's 41st Minority Health Conference. And for those who are unfamiliar with Taneisha Brown, she is a community organizer, political strategist, and also one of the co-founders of the Black Voters Matter Fund. This event was led by a PhD student who invited me to help lead a discussion amongst students and faculty members in response to the keynote. And I vividly remember emphasizing a point during our discussion that relates to the significance of interdisciplinary scholarship. I said the intellectual challenge we face in discussing health inequality is that our academic disciplines largely discipline us into thinking within a constricted lens. It's important to note that researchers in the sciences and the humanities explore health inequality based on disciplinary boundaries, which determines their research questions and methodologies that produce knowledge. To be clear, I'm not inferring that any discipline is off base. Instead, I'm claiming that our research cluster's willingness to embrace and engage interdisciplinary scholarship has illuminated the pieces of the puzzle that illustrate health inequality. And this is extremely important because the power dynamic between the sciences and humanities is not equal regarding funding and the validation of evidence. Now, some may overlook or ignore, the evidence in the humanities. So as a person situated in this field, I think both categories, sciences and humanities, enable us to widen the view of health inequality. And the research cluster has granted me the means to hone my perspective as a humanist. Lastly, the research cluster is a space where humanists like me are exposed to medical doctors and medical students' views on health inequality. The pandemic certainly unveiled challenges medical doctors face in our healthcare system as it was pushed to its limits. But aside from the pandemic, medical doctors endure ongoing challenges inside and outside the clinical setting, before, during, and after the pandemic, as it pertains to health inequality, and that was already alluded in the previous comments. And also, I've learned about medical students' challenges with reforming medical education in ways that seriously engage the humanistic components of health. As a result, these discussions have sparked research questions about the pros and cons of being a medical doctor or student operating within a social justice framework. So I'm sure my time's up, but I emphasize these points because my experience as a graduate student in this research cluster has ultimately assisted in formulating my research interests, and it has also provided me with countless literature that I've shared with undergraduates in my TA appointments, extending its impact beyond the cluster into the greater Brown community, insofar as the students I've been able to interact with. But that's all I have for now. Look forward to engaging you in Q&A. Thank you.
Thank you.
That was great.
Okay, we have about 12 minutes. Who wants to go first?
Good afternoon. My name's Dr. Schleter. I'm a family medicine physician, graduate of Brown in '93, went to medical school in Case Western Reserve in Cleveland, Ohio, then did a family medicine residency in Columbia, South Carolina, and have been working at a community health center since 2000. And so my healthcare experience has been as a family physician working in underserved communities, South Carolina. We're talking about predominantly African American. And so I really appreciate the title of this cluster, Race, Medicine, and Social Justice, because to me, healthcare reflects everything about social injustice and inequities. and that it is the summation of people's experiences in the society that we have. And what I've come to appreciate is it's about the exam room. You have a clinician and you have a patient, and then you have shame, and the shame comes from, well, you know, this is something that you did on your own, okay? Your health inequity result came from your own misfortune, your own decision making, and so it's your fault, okay? And I find that that is kind of ironic with everything, understanding that as we've learned today about, we talk about social disparities of health, and actually the actual health outcome is maybe about 20% about what happens in the exam room, about 80% that comes from your social environment, that comes from maybe your social beliefs and everything, but about 80% is about what happens outside of the exam room. But we do know that a big part of what happens is clinicians' own beliefs when you're having that private conversation in the exam room, and what that clinician is going to recommend or omit from the conversation. And that has a big difference, understanding that many of our patients just don't know. And they're expecting what is presented to them is what is presented to everybody else. But we know that the studies show that that is not the case. And so, you know, this is a huge challenge, because the people in the communities that I serve are kind of blowing in the wind whatever policies that are created, whatever life environment that they're a part of, and especially when you have these social determinants and don't have access. Just moving forward, you have insurance, you don't have insurance, you have transportation, you don't have transportation, you have a job, you don't have a job, you're trying to take care of your children, but then you have a job, and how do you balance it all together? It is difficult. And so when we think about the end result of racial disparities, yes, our bodies are the same, but the inputs that we experience over a course of a lifetime is vastly different and has a strong impact. And how do you account for all of these life experiences? Then the last thing that I've appreciated is for those who have done well financially, we might say, of our entertainers and folks, but they still die early. And there is the stressors of life that come. And yet, even when you have the financial means, still we experience those inequities that we think just having money would erase, but it doesn't. And that again goes back to that life experience of stress and racism that we experience regardless of our social standing as minorities in this country. So I really appreciate this. Everything that you guys shared could be, you know, a year-long, you know, CDC, Health and Human Services forum to try and figure out. And what I would say is, with what you guys are sharing, from my understanding with where CMS, Medicare and Medicaid services, health inequities is forefront, but it's how we are able to put this into something that is so massive and impacts, you know, so many people on a day-to-day basis. So that's just what I wanted to share.
Well,
Thank
thank
you.
you very much. Good.
Please join the cluster. You're not here.
Questions, comments from anyone else? Yes, please.
Hi, my name is Ella. I'm a third-year medical student. Hi, Dr. Ritchie.
Hi.
I have a kind of specific question that was from one of our didactic sessions yesterday. We were talking about the different calculators that people use and like have to use. And my question, it was this family medicine doctor who was doing our lecture, and my question to him was, what do you do when we were talking about the cardiovascular one where you have to put like white, black, or other? And I said, what do you do? in that scenario, and he said he has his patients choose which one they choose to identify as, whether it's, based on how they identify the race or just what they want to choose. And I asked him what he thought about just choosing white for all patients, because in my mind, the calculators were made assuming that race is something biological affecting medical outcomes when we know it's not. And his opinion was that it was a form of supremacy to just select that as like the default for patients, and that and I wasn't sure how I felt about his response, and I wanted to get your thoughts on using that in clinical practice and just also on a theoretical standpoint too.
We
Great.
have the expert here.
Great, thank you.
Go ahead.
Lundy.
Was this okay, this is the didactic the other
It was,
day.
yes, yesterday.
So I've thought a lot about it because it's coming up with PFTs, pulmonary
Yeah.
function tests, right now. And there was a big conference that decided on using a global population-based standards. Those global standards still were race-based. So we have a lot of trouble getting away from race, certainly in pulmonary medicine. My answer to that is use a whole population that has everybody in it, that you don't predetermine races. There's no reason for the cardiovascular, and in cardiovascular medicine, they're really fixated on this, and then others have to use it, you're right. We could ask the family medicine physician here what he actually does with those, but my view in pulmonary, which is where I've worked, is use population standards that are people from all, and then apply it. But that really, nobody can seem to do that. The race is so built into our consciousness that somehow there's answers like it's white supremacy, or, but if it was just mixed, white, black, whatever, if these races are not genetically determined, then why not have populations based on the large groups of people?
I must say your solution to use the default as the default, why not? And saying that, well, I don't choose white for all my patients because I feel like that's a white supremacist thing. You're just like, well, I mean, white supremacy is a thing. And my solution, or choose other for everyone, right? Because we're saying that there is no genetic basis for what folks experience. But what we just discussed, though, is that while there is no true genetic basis, your lived experience, right, does impact your health outcomes. And so to acknowledge that racism and not so much race goes into the machine, I think there's an argument for that in 2023. And I'm hoping by 2050, when we all have access to everything, that we can completely remove these categories. I would argue that right now we are unable to do so, because the real fact is that if your patient does live in 02903 and that's their zip code where their house is, and they are Black, it's probably very true that their lung function is not the same as someone else, right? And perhaps the argument should be, you should have zip codes in your machine. It's not so much a race. It's not about who, but where, right? And so perhaps that is our ultimate solution. We put your zip code in now while we acknowledge that racism exists. But I think your solution was great. Perhaps he could have come back to you and said, well, sure, I'll choose other for everyone. But perhaps that's not going to give our patient the best outcome, because their lived experience is really different. And it is predicated by how they look. So.
The final question, I'm afraid.
Okay.
Thank you. I want to thank you for a wonderful presentation by all of you, and also for your work at Brown. I'm Pat King. I did my PhD at Brown a number of years ago, and am now a physician working at the University of Vermont, a general internist and I've done a lot of work in education at the medical school. So this is just incredibly complex, and social determinants, and I mean, it's so complex. But I'm trying to get to a couple of, or one thing in particular that I think is day to day, which is the diversity of the physician population, maybe the diversity even of nursing population and all of the professions within medicine. So it is a huge topic and a very active component of admissions. So I wonder if you have looked at this and done any or have any plans to follow this over time. I also want to say I certainly appreciate your comments, Eric, about the disparity of funding between humanities and science. I mean, that is definitely the case, but I think just looking at our workforce within medicine is a big issue.
All right, great. Thank you very much. Panelists, and then this is our final.
Have we left it?
We've talked about workforce a little bit, but
Not necessarily. You know, the thing is that, you know, people think that, well, sometimes, yes, it is good to have people see others that are like themselves. However, sometimes you can't necessarily say that we're all brought up in the same system, right? And so sometimes it doesn't necessarily mean that they are going to act differently than the dominant culture. So we need diversity, period. That's something we need. But we need to have a conversation about what we're learning and how to change it and shift. And, yeah.
Okay, great. Thank you all very, very much.